All right, so here's the lecture for Module 4. We're going to talk about drugs affecting the respiratory system. So these are going to focus on treatments for asthma and COPD, which for the most part are the same medications. The change is going to be the order you use them in, for what stage of asthma or COPD, and then the medications you use once you get through those kind of first and second line options, what comes after those. So in general, we're going to talk about bronchodilators, then leukotriene modifiers. So you'll see one like that is like Singulair. Inhaled corticosteroids, oxygen, antihistamines, decongestants, and cough preparations real quickly at the end. So beta 2 agonists, short-acting beta agonists, are a mainstay of as-needed therapy in COPD and asthma. You see these in kids at an early age if they have exercise-induced asthma, and a lot of times patients will use it for an asthma attack or for a COPD exacerbation. You'll see them using 2 puffs every 15 minutes if it's an attack, and then you want to, if it's just in between, just normal shortness of breath, you'll use it every 4 to 6 hours. When you watch the use of this to see what stage COPD or asthma they're in, if they need to have more controller medication, or if they're not using it very often, if we can kind of pull back on those controller medications. So the most common one you'll see on this list is albuterol. You have ProAir, Ventolin, and Proventil. They are all the same albuterol. The difference is the inhaler they come in. They're made by 3 different companies, and the reason you'll have to figure out which one is for insurance purposes. A lot of insurance companies will pay for Ventolin, but they won't pay for ProAir. It's just like saying they'll pay for Motrin, but they won't pay for Advil. It's still ibuprofen, but this is still albuterol. So if you want to make it easy for yourself, just write it for an albuterol MDI, meter dose inhaler, and the pharmacy will pick whichever one is on their insurance formulary. The other one you may see used on this list is levalbuterol, Xopenex. I haven't seen any of the other ones used as a short-acting beta agonist. Maxair, I've seen on the shelf in the pharmacy. I've never actually seen it prescribed, that perbuterol. But the levalbuterol is the active isomer of albuterol. So think of it as taking, we won't jump way back into organic chemistry, but there's 2 chemical structures of albuterol, and they've taken one and put it in this inhaler for Xopenex. It's an inhaler or a nebulizer. Now the marketed benefit is that you use a lower dose of albuterol, or levalbuterol. Again, I said marketed benefit because it's a lot more potent. So it's more potent, but it's a lower dose, so it's essentially the same thing, but a lot more expensive. Very few insurances cover Xopenex. It still causes the tachycardia and the tremors that a short-acting beta agonist like albuterol can cause. There's really not a benefit to Xopenex over a much cheaper albuterol inhaler. So long-acting beta agonists, you're going to see a lot of these. And your beta agonists are going to be anything that you see that ends in that terol. So formoterol, salmeterol. These are going to be in combination by themselves and in combinations with other inhalers. One of the great things about any treatment for asthma and COPD, a lot of them come in combination inhalers, so you're not having to buy 2 or 3 inhalers. The problem with that is that you have to remember which brand name is which. Is Symbicort, is that the formoterol by itself, or is that formoterol and budesonide? But the inhalers are really beneficial because it does help decrease the burden on patients. So here's some other charts that you can see. I've pulled from different resources that talks about albuterol and levalbuterol, the brand names of the inhalers, the doses, and the side effects. Again, you can see it's the same side effects and pretty much the same notes on administration. The long-acting beta agonist, you're going to see here again. It goes through those categories. Same tremors and tachycardia as the main side effect, and that's to be expected. Your beta cells are in your lungs, but also in your heart. Beta blockers will help treat a tremor and lower your heart rate. So a beta agonist is going to do the opposite. It's very short-lived. Most people who have a long-acting beta agonist don't have a tremor and tachycardia, but the short-acting ones can, usually for about 15 minutes. These are talking about each one's independently. Precautions, again, not a reason to not do it, but cardiac arrhythmias, you want to make sure that they're stable, they're on their medication. Diabetes, potential drug-induced hyperglycemia. That's not the biggest issue we see with beta agonists and diabetes. I hardly ever see a drug-induced hyperglycemia, but I think we talk about it in a little bit, but I'll go ahead and mention it. That your beta, we'll talk about that at a different time. Sorry, I'm getting ahead of myself. But this hyperglycemia is very, very rare. Long-acting beta agonists, you can see that there is a risk with these when used with asthma. We'll talk about it again in a little bit. By themselves, long-acting beta agonists actually increase the risk of events and death due to asthma attacks. So when you're using it in asthma, you always want it combined with an inhaled corticosteroid. Luckily, they come already manufactured that way, so it's real easy to have the patient still take one inhaler. Terbutaline, not used anymore. We'll just move on. You may have a patient who's been on it for a long time or use it as a last line resource. I've never seen it used. In 12 years of pharmacy, different settings, I've never seen it. These ADRs are fairly straightforward. Beta agonists, clinical use, bronchodilators are going to be primarily used in COPD, and then they're going to be primarily used in combination with an inhaled corticosteroid as a maintenance medication in asthma, with a short-acting one used for PRN asthma attacks or shortness of breath. So there are different guidelines out now for COPD. There's the EPR3 and the GINA guidelines. The GINA guidelines just got updated, and I believe those updates I've put on Canvas. The GINA guidelines are a little bit more. They just got updated in 2019, which is very recent for guidelines. The other ones are about 10 years old, so continue to look at that. They've actually made some recommendations for long-acting formoterol. Formoterol to be a rescue inhaler, in combination with an inhaled corticosteroid. Right now, it's not accepted. Most insurance companies won't pay for it like that, but I think we will see that change soon-ish, maybe in the next couple of years, because the outcomes are just much better. Again, long-acting beta agonists have a warning. You cannot use them alone for patients with asthma because of an increased risk of a severe exacerbation and risk of death from asthma attacks. You should always use it with an inhaled corticosteroid, and you should consider stepping down or discontinuing the long-acting beta agonist if a patient is well controlled for 3 months or more. Xanthine derivatives, I've seen this used one time, and it had nothing to do with COPD or asthma. You can review them. Theophylline is used so little now, they've taken the 100 and 200 milligrams completely off the market, and they have 300 available just in case someone needs it. But you can keep looking. It's an aerotherapeutic medication. It's got lots of drug interactions, lots of side effects. We got a lot of other meds. We just don't use it anymore. So we're going to keep skipping over these. You read these, you can see there's a lot that goes into these medications. There's a lot that can go wrong with these medications. So you're not going to see these used hardly ever. Inhaled anticholinergics. So you're going to see these used a lot. They're going to be used mainly in COPD and kind of the last line in maintenance of asthma. You have they are maintenance medications. They are not rescue inhalers. It's important that your patients know all the time that what is their rescue inhaler and what is their maintenance inhaler, because most of them do not act fast enough to be used as a rescue inhaler and a maintenance inhaler. So you have Atrovent, tiotropium, and aclinidium, which is one of the newer anticholinergics. There's more coming out in this category, and they're being combined with other inhalers to really broaden the market for these. So they're really good. They block the muscarinic cholinergic receptors in the lungs. So here are your generics, your brands, doses, adverse effects that you can see with it, and any comments about how to use it, how to prescribe it. They have slightly different inhalers, each one. So you want to make sure that they know how to do it when they use it. Each one has little tips and tricks on how to use it. So again, this is another one of those drugs, and they get it prescribed. Go over it with them. Have them talk to their pharmacist about it, because just like the Spiriva HandiHaler, this one right here has capsules you have to put in the inhaler, and when you put them in there, you puncture them using like a clicker on the side of the device. They inhale it, and if you hear the capsule whistling, rattling around in there, then you know you've sucked all the medication out of it. And you can take as many breaths as you want, but you want to hear that rattling sound. Then, very important, you take that capsule, you never put it back in your hand. You dump it straight in the trash. If you put it back in your hand and then touch your eye, you have just given yourself an entire day of having your eyes dilated. And it's going to take all day for that to go away, because it's a long-acting anticholinergic. So little things like that they'll need to know for these medications to make sure they take it right and don't have adverse effects. Nothing that's going to hurt them, but they definitely don't want to ruin their entire day for something kind of as silly as that. Just a few precautions. Do not use an acute bronchospasm. These are category B and C medications. They're very, very useful in pregnancy, and they're not approved for anybody over age 12, but they are currently being looked at for that. You'll see a lot of things that are not FDA approved for certain things, but they are used off-label, which means they're not FDA indicated, but they're still used. You'll see that actually quite a bit. Cough is the most common adverse drug reaction. Dry mouth is very common. Again, it makes sense. Our anticholinergics, whether they're oral or inhaled, cause side effects that dry you up. So here, with inhaled anticholinergics plus oral, like Benadryl, Zyrtec, things like that, Claritin, they're going to cause dry eyes, dry mouth, urinary retention, and constipation. The way to remember that is for anticholinergic side effects, you can't see, you can't pee, you can't spit, and you can't shit. So real easy to remember the side effects from it. So we get the uses of medications in COPD, the uses in asthma. Again, most of these medications are used for both, but where you use them is critical. What's first line, what's second line? These inhaled anticholinergics are going to be used fairly quickly in COPD, but they're going to be last line inhaled therapy in asthma. Leukotriene modifiers, real quick before we jump into inhaled corticosteroids. These are effective. The one you're really going to see mostly is montelukast or Singulair. They come in tablets and chewable tablets. So a lot of times you'll see them for children, for asthma, or especially allergic reaction asthma. So if they're allergic to pet dander or dust or something like that, you'll see them help with allergies. People who have really bad, nasal allergies. See it used in children and adults. We don't see Zafirlukast used very often because of because of hepatic dysfunction that it can cause. Look for hypersensitivity, adverse drug reactions, headache. Usually that's about it. You will see, you can possibly see some mental status change if you see some patients who are agitated or anxious on it. You want to stop them. We actually took Singulair off of our formulary at the psychiatric hospital because of that risk and because of low usage. If a patient already has a psychiatric disorder, it's probably something to take off to make sure it's not exacerbating it. Here's where the populations for the patients. You want to monitor for any worsening asthma symptoms, how often they're using the bronchodilator, and again, check your GINA and your other guidelines. They have great charts that I think are coming up soon. I'll show you examples of if they're using their emergency inhaler more than twice a week or more than twice a day, then they need to be on this step of therapy until they're controlled, and then we can back off. Their pulmonary function tests. So we're checking their FEV, FCV, or FVC to see how much output they can have and how strong they can breathe in, and any new onset of neuropsychiatric symptoms. Again, your first symptoms with those medications are going to be kind of an agitation, anxiety, so watch out for those. Corticosteroids, the benefits are seen the greatest in asthma. This is going to be your backbone of maintenance therapy for patients who have asthma, whether it's exercise or allergen induced. You want to avoid if using for relief of acute bronchospasm. Again, it's not a rescue inhaler, and it's not a substitute for oral corticosteroids if they're having a severe reaction. Watch out for patients who have Cushing's syndrome, pregnancy, these other things, because it's a steroid. It's going to make the Cushing's syndrome worse. So you've got several different versions. Their brand names all have similar dosing, all have similar side effects. The one you're going to see the most, if you're going to see anything, is this oral candidiasis. Now, to prevent that, all they have to do is wash their mouth after using it. You're giving a steroid to the mouth, which is going to give an opportunistic infection for a fungal infection of candidiasis. Easy to treat, gentian violet, some kind of an nystatin, swish and spit. Very easy to treat, easy to kill, but to prevent it, just rinse their mouth out after they're done using it. One that people are worried about, for not a lot of reason, you'll have parents worried about this, is that it may slow the bone growth in children, but a small reduction in adult height with persistent asthma. So, what does that mean? What does it actually mean in practice? Within the first year of therapy, inhaled corticosteroids can prevent the growth of someone's height by 1 centimeter, and then they maintain their growth throughout adolescence. So you're going to lose a centimeter, or about 1/3 of an inch, overall to have your asthma controlled. That's a very small price to pay to prevent the asthma attacks that can be deadly. So when you're talking 1 centimeter, it's not worth them not getting it. So please help them, talk to them about this. If they're worried about it, tell them what it actually means. So for asthma, you're going to use, for persistent asthma, inhaled corticosteroids. That's going to be your first step in routine scheduled therapy. So if they need anything more than an albuterol or a rescue inhaler, it's going to be an inhaled corticosteroid, and then you're going to use it in combination with other medications. Spacers, you'll hear about those, especially for children. That is just a plastic tube that the medication can be released into. You connect it to the inhaler. Patient puts it up to their mouth, releases the medication, and they can use it to breathe in and out. If they need practice and they're not quite sure if they need one, have them use a paper towel roll for a little bit, or a piece of PVC pipe, and see if it's beneficial. If it is, then write them a prescription. They're $20 to $30, I believe. They are prescription only, but they're really beneficial for patients who have a hard time. It fits up to the mouth very, very nicely, Some even have a mask that you can get for younger children who don't want to do a nebulizer because that takes a lot more time, but aren't quite ready to do their inhaler by themselves. And it just gives you an opportunity to breathe in and out several times to get that medication deep in the lungs. This shouldn't have to be put in here. If they're needing this medication, they need to avoid or quit smoking because that's just going to be a trigger and make everything worse. Here's a list of combination therapies. There are more hitting the market. This is not by any means inclusive. There's now some that have all three categories in them. I think it's even on the TV right now, an advertisement. I think it's Trelegy for all three of them. Haven't used it yet, but we do have it available for patients because one inhaler is a lot easier than three, and one copay is a lot cheaper than three also. One of the reasons we're not seeing so many people use drugs like theophylline and those older drugs is because we're coming into the class of monoclonal antibodies, which are, given another 15 years, are just going to revolutionize treatment for lots of disorders. These were really starting to kind of hit the market, around 2010, 2008, and have only, we're seeing 20, 30 added to the market every year. They're very effective. They're very easily or well tolerated, and with few adverse drug reactions. And they're excellent for treating anything from cancer to seizures to migraines to COPD, all that. And it goes for a specific receptor, so it's very well tolerated. You also have phosphodiesterase 4 inhibitors, or Daliresp, used in COPD, very severe. This is going to be one of your last lines of therapy with the monoclonal antibodies. Just some information about that. You'll probably only use this if you are working in a pulmonologist office. Probably the only reason, or you'll see this, the patients are coming in on it, and we're just going to keep it going if they need something this severe. Oxygen, most people who have COPD will at some point get put on oxygen. None of our treatments for COPD change the course of the disorder. We are just trying to decrease the symptoms and then try to get them to quit smoking so that the COPD doesn't keep getting worse. But then you put somebody on oxygen to help with if they have exertion on normal daily living functions, just walking around their house, getting through work. You put them on oxygen. Obviously, avoid smoking because oxygen's flammable. You'd be surprised how many people you have to tell that. Adverse drug reactions, not a whole lot on here. You'll get it dosed, monitor, a little bit of pulse oximetry. Usually, the patient will tell you, "I feel really good" or "I still feel crappy." So you'll know how well it's working. There's still lifestyle management that has to be done with it, but again, that's going to be your last line of therapy. And at that point, it's just symptom control. Antihistamines, oral, we're going to use them for allergies. Some people use them for sleep and seasonal allergies. So we're blocking that H1 receptor. Now this should have been up one slide. Here are those GINA and the EPR3 guidelines. Which step in therapy? You can see it's based on the severity of the diagnosis, how often they're using their as needed medications or their rescue inhalers, what their controller therapy should do. Always, always, always have a short-acting beta agonist as needed for rescue therapy, unless we get that change and insurances start covering that formoterol, which is what we're going to talk is briefly right here. I'm not going to read over all of it, but they've discovered that regular or frequent use of a short-acting beta agonist has adverse effects because it causes beta cell receptor downregulation. So you have less receptors for that beta agonist to come in and work on, which is not uncommon when we hit certain receptors in the body over and over and over again. And shorter use of short-acting beta agonists because of that is associated with adverse clinical outcomes, more hospitalizations and more deaths due to asthma. So there are trials currently that have been done and are currently being done, looking at looking at low dose budesonide formoterol in mild asthma, and these using that is not showing the same negative outcomes as the short-acting beta agonists. So that combination in inhaled corticosteroid is helping to mitigate that downregulation of beta receptors. Plus, it gives a longer effect so that they don't need several more doses of that rescue inhaler. Asthma treatment overview. You can read through those. Very helpful guidelines-based recommendations. COPD, these are the gold guidelines. These are what they're recommending depending on which patient group you are. Here's the combination of medications you're recommended to start with. Obviously, if you have a patient who is category C and the long-acting muscarinic is not controlling them, you would add another medication. But this is where they recommend for you to start. Again, initial treatment. You still treat the patient's symptoms, and then if they're doing well, try to pull back so that they're on as little as possible. A few things to note. Existing medications for COPD have not been shown to modify the long-term decline. The only thing they can do is to stop smoking or get away from whatever is causing that COPD. They do not help reverse that physiological change. So again, continue on the treatment overview. So back to antihistamines. You got your first generation antihistamines, most commonly used as diphenhydramine or Benadryl. Second generation are non-sedating. That's your Claritin, your Zyrtec, your Allegra, and all those other ridiculous expensive allergy medications that most people aren't gonna need. Some will, but these second generations, those for seasonal allergies, are all equally effective in a population level patient or treating for a patient. So 95% of people are going to get control, whether it's Claritin, Zyrtec, Allegra, Clarinex, whatever those other ones are that are really expensive. So start with the least expensive and work your way up. Whenever you have a class of drugs like that, go for cost and whichever one you only have to take once a day, and then go up to the more expensive ones. Pregnancy category B, so they can be used in pregnancy, not for newborns and infants. These can be used in children. You're commonly going to see when a first generation is given to a child, you're going to see a paradoxical effect where it ramps them up as opposed to making them tired. So don't be surprised if you see that. You'll see a lot of children getting these medications for seasonal allergies or for cough and cold symptoms. Side effects, again, not surprising. The big ones you're going to see with first generations are sedation, and then those ones we talked about earlier, dry eyes, dry mouth, urinary retention, and constipation. Mostly to treat those last two, just tell them to drink some more water, and it'll go away. Second generation, very little drowsiness. Most don't know they're taking it, but probably want to watch out for that constipation and urinary retention just in case. Decongestants, obviously used for when they have a stuffy nose. There are two that are on the market. Let's see if we can get. No, I think they're. So the two on the market are phenylephrine and pseudoephedrine. Phenylephrine is over the counter. It is the only decongestant in every cough and cold medicine over the counter in a pharmacy. Anything that's behind the counter doesn't require a prescription. Anything that's behind the counter they have to show their driver's license for is pseudoephedrine or Sudafed. You'll hear a lot about that because there are legal limits on how much you can buy per week and per month, because that's one of the most important ingredients in making meth. So you'll have people who seen a lot of this, different ways people try to buy it. They buy it with gift cards in the pharmacy. That way there's no name attached to it. And they try to buy the short-acting Sudafed. So that 4-hour one, very easy to get to use that to make meth. If your patients do have something, they need it constantly for seasonal allergies. I take it every day because I have horrible dust allergies, but I get the Claritin D 24-hour. It's a lot harder to separate the Sudafed out when it's in an enteric-coated combination tablet with Claritin. But those are the only two decongestants on the market. We'll talk about Mucinex in a little bit. Mucinex is not a decongestant, and that causes some confusion when a lot of times when people are coming to the pharmacy looking for medications. Common side effects, restlessness and tremors. It will increase your heart rate and increase your blood pressure. So people who have uncontrolled arrhythmias and uncontrolled blood pressure, they are not to take these medications. They do make over-the-counter medications called Coricidin HBP, and that's for people with high blood pressure. So you want to recommend those. If a patient has well-controlled hypertension and they have a cold, they can go ahead and take their, they can get some of the decongestant. And we're really worried about those people who have uncontrolled hypertension, or they have an uncontrolled arrhythmia that they're constantly in and out of AFib or VFib or something like that. So VTAC, we want to watch for those patients. So you'll see here the uses of it. They may count in this the nasal sprays for decongestants, those Afrin sprays. The one thing to watch out for those is after 3 days of use, it actually causes rebound congestion. So it comes back worse, and it creates just a cycle of having to use more and more sprays more and more frequently to get rid of the congestion until it just doesn't work anymore. I've read some stories about singers who have kind of gotten in that cycle because they got to perform the next day, so they'll use it so they can sound fine, and then it just creates a cycle where you kind of just have to stop and deal with the congestion for several weeks before it goes away. Again, that's with more than 3 days of use. But the saline nasal sprays, tell them to go for it. Those are a good substitute. Antitussives. So we're going to talk about over-the-counter first. Over-the-counter antitussives, the only one on the market is dextromethorphan. That's it. Every cough and cold medication has that one cough suppressant in it. Even Delsym, which I think it works the best of any of them, it's just a 12-hour version of dextromethorphan. So all the ones, the Robitussin DMs, anything for cough, it's all the same drug. Then you've got some by prescription, which are usually some kind of opioid, Tussinex or something like that. It helps. It works. Causes that slight respiratory depression, mu stimulation, and gets and causes the cough to go away. So you always want to increase your fluid intake, refrain from smoking, and avoid respiratory irritants. So those are fairly straightforward. Expectorants, guaifenesin. Guaifenesin is the only expectorant approved by the FDA. I personally, I don't like Mucinex. I don't like guaifenesin. I think a lot of times this gets prescribed in error as Robitussin. So Robitussin itself is liquid guaifenesin. Guaifenesin only thins the mucus so you can cough and clear it up. Drinking a lot of water will do the same thing. But it doesn't hurt. There's no drug interaction, so go ahead and get it. But a lot of people will say, oh, you've got a cough. Here, go get some Robitussin and use it when you cough. Well, it's not going to help prevent the cough. It's going to help them clear that phlegm, that chest congestion they may have that they just can't get rid of. Adverse drug reactions taken in normal limits, normal amounts, they're not going to have any drug interactions. May cause false lab readings for these. Haven't really run into that issue in the past. It's used for mucus in the respiratory tract. That's what it's used for. Quickly, smoking cessation. The options for smoking cessation are nicotine replacement therapy, Wellbutrin or Zyban, which is bupropion, and varenicline, which is Chantix. All of them are very helpful. They can be used in combination, which we'll talk about later, whatever gives your patient the best chance to quit smoking. Because every time a smoker comes into your office, you want to ask them, You just want to assess if they're ready to give up smoking. You can't be pushy. You can't force someone to do it. Research, look up the 5 A's for treating smoking cessation. But you want to ask and assess how they're doing. And then that way when they are ready, you're able to assist them. So here are your options. Nicotine replacement therapy to slowly, gradually titrate off Wellbutrin or Zyban, bupropion, and Chantix varenicline. Nicotine replacement therapy. You're going to have a few options. Over the counter, there's gum, the patch, and the lozenge. The patch is the most popular kind. You can slap it on in the morning. You get steady nicotine throughout the day to help prevent cravings. And then you can take it off at night, or you can take it off when you put the next patch on. Now what to watch for with the patch is skin irritation, because there's an adhesive. And if they wear it overnight, it can cause very vivid, realistic dreams. So if you have a patient who's tried the patch, they're complaining of nightmares, you want to recommend that they take their patch off before they go to bed. The next most common is the Nicorette gum. That gum is very common because you can use it as needed for cravings about every 2 hours. They're going to chew it. When they chew it, that's not where they're getting the nicotine. They've got to take that chewed gum and park it in between their gum and their cheek, below their teeth, and then it's absorbed into the mucous membranes. If they feel that it's not giving any nicotine, they can pull it up, chew it again some more, and park it again, and keep doing that until there's no more left. The lozenge, don't see a lot of people using it because they say it causes, as it dissolves and it goes down their throat, it causes horrible heartburn. But if they try it and they like it, let them go for it. The prescription drugs, nasal spray and inhaler, I've never seen these used. Insurances do not pay for them. They're like $150. They burn, they hurt. I haven't seen anybody use it, but if they want to try it and they think that's going to help, then go for it. E-cigarettes are not recommended. E-cigarettes do not help someone quit smoking. Got the precautions here. Again, I would say these are contraindicated after a stroke and a myocardial infarction, but so is smoking. Which one's worse, nicotine replacement therapy or smoking cigarettes, all that tar and nasty stuff we're burning? So, nicotine gum, the dosing is based on how many cigarettes a day you take or you smoke. It tells you how to chew it, how to park it, which dose to use. The lozenge shows you how often to use it. Transdermal patch, there's 2 tapers based on how much you smoke. One that starts at 21 milligrams and one that starts at 14, and they're a 42-day taper to try to get off of it. There's no problem if in 42 days they're not ready. They can continue taking the medication. At our hospital, we've got some patients who might be there a couple months, and if they say, I'm not quitting smoking, we have some that they stay on the nicotine patch the whole time because we're a smoke-free facility. There's no negative from that. If that's what they're going to do, at least it helps prevent those cravings. Bupropion, you start at 1 to 2 weeks before your quit date. Here's your dose. And then on your quit day, you quit cold turkey. You can use nicotine replacement therapy with this product. That's very beneficial for patients who are just nervous about quitting cold turkey. They continue for 7 to 12 weeks, a little bit longer if needed, and then they taper off the medication. Contraindications, just like if it's in depression, seizure disorders because we lower the threshold, and eating disorders because it cuts the appetite. You'll see weight loss also with patients who are on bupropion, which is a concern for patients who stop smoking. Most of them gain weight because they got to have that hand and mouth fixation. They snack instead of smoking now. So watch out for that. Neurological disorders, avoid in pregnancy, and you don't want to give it to someone who's already taking Wellbutrin. Adverse drug reactions, insomnia, dizziness, and dry mouth. That insomnia is just from an increase in energy, so have them take it in the morning. If they're taking it twice a day, maybe take it at 9 and 5. Don't wait until bedtime. Chantix. You're going to start it a week before a quit date. Both of these are equally effective. Your patient can pick which one. Chantix comes in a nice titration pack. So you do 0.5 daily for 3 days, 0.5 twice a day for from 4 to 7, and then 0.1 or 1.0 twice daily after day 8, and then you continue for 12 weeks. Adverse drug reactions: nausea, most commonly seen. You do have neuropsychiatric symptoms, changes in behavior, depressed mood, suicidal ideation. This has actually been pulled back a little bit. It's no longer a black box warning. You actually could not fly a plane if you were on Chantix. You couldn't be a commercial pilot because of that suicidal ideation, but that has been pulled back because the more and more people took it, the more they saw that that was a falsely elevated risk. There's never actually been any linkage to someone doing that on Chantix. I'm not really quite sure where it came from, but the risk seemed to be a little exaggerated. But you may not want to use this in a patient who already has these symptoms. But if you got somebody who has suicidal ideation and is depressed, put them on Wellbutrin for smoking cessation, and they get an antidepressant at the same time. You can use clonidine as second-line treatment if they do happen to fail. The first ones, same side effects to expect if you're using it for cardiovascular benefits. Again, therapy is very helpful. Obviously, pregnancy is a good time to have somebody quit smoking because of the benefit to the child in utero, and once they're born, it's a good time that people kind of make good changes for themselves and for their children. You want to monitor withdrawal symptoms. That's why they're going to quit taking it, as if they have those uncontrollable symptoms. Nicotine toxicity if they're getting too much, and any neuropsychiatric changes you may see. Right here we've got some slides on fluoroquinolones. These are I'm not sure where antibiotics are in your book, but we used to cover fluoroquinolones in the COPD section because they're commonly used for respiratory infections. So this is just for completeness. This is just for you to have that information. And then also antivirals, the baloxavir and oseltamivir. So that's Module 4. If you have any questions, shoot me an email or send me a message in Canvas.